Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers, and today the topic is xylazine, an animal tranquilizer that's showing up in illicit opioid supplies. I speak with Rachel McFadden, a Bloomberg Fellow at the School of Public Health and a wound care nurse at a harm reduction organization and nurse in the emergency department at the Hospital of the University of Pennsylvania, and Dr. Matthew Salzman, also a fellow and assistant professor of medicine at Cooper University Hospital in Camden, New Jersey. We talk about why xylazine is so dangerous and why this could be a pivotal moment in the opioid crisis. Let's listen. Rachel McFadden and Matthew Salzman, thank you so much for joining us on Public Health on Call to talk about xylazine. So we're going to start out, first of all, by talking about what is xylazine? Where is it showing up? Why is this such a problem? Rachel, I'm going to start with you.
Thanks, Lindsay. It's great to be here. So xylazine, which we also call tranq, is a veterinary sedative, and it is not FDA approved for use in humans. But in the last several years, it has found its way into the illicit drug supply and primarily the illicit opioid supply. And this isn't the first time this has happened. So really the first published literature on xylazine in the illicit drug supply is from Puerto Rico in the early 2010s. And at that time, researchers and harm reduction workers noticed a much more significant sedation and a very distinct kind of wound in folks who are chronically exposed to xylazine in the drug supply. Now, in addition to the emergency department, I work in a wound care clinic partnered with the local syringe exchange. And in early 2020 or late 2019, people coming into the clinic started noticing these strange ulcerations or wounds, in addition to a largely undesirable change in how they felt after using illicit opioids. And they could actually avoid these things initially if they switched to a different stamp. And stamps are kind of like the brand of street purchased drugs. But they were saying, we think this is tranq. And they were right. So now, 10, 15 years after Puerto Rico, what we're seeing in Philly and radiating into other regions is pharmaceutical grade xylazine in the illicit fentanyl supply, having the same kinds of effects that were first documented down in Puerto Rico. So significant sedation and this new kind of wound typology. And I think it's just so important to emphasize here that people using drugs were the first to raise the alarm on this in Philly before it was at the crisis level that it is now. Now, most of the folks in our clinic don't like going to hospitals. Hospitals are really out of reach for most people who are dependent on illicit opioids. And kind of working in both hospital and harm reduction worlds, I see all the time how stigmatizing care and untreated withdrawal continue to be really big barriers that functionally exclude these folks from getting hospital care. But pretty soon, it was just no longer possible to avoid xylazine. As we know now, it became ubiquitous in the street supply. So more people were developing more wounds, and these wounds got worse, and people started getting sepsis or losing large areas of tissue. And only then did we really start seeing them in greater numbers in the hospital. So now we're seeing folks more frequently in hospital settings with these wounds, but often at very late stages and only when they're quite sick.
So you have a group of people that is dependent on opioids that they are injecting, and they're getting these wounds. And I've seen photos of these wounds. They are horrific wounds. This is not a small infection. And tell us, is this happening at the injection site or throughout the body? And tell us what the prognosis is for these kinds of wounds.
So we see them actually in two scenarios. So at the sites of injection, they tend to start deeper and progress faster. But we also see them away from injection sites, which is one of the hints that this is really related to the supply. It's not just at injection sites, it's just the systemic exposure to xylazine. And anecdotally, in our clinic, we have also seen these wounds develop in folks who say they are primarily snorting or smoking and not injecting. So again, some evidence that it's supply related, these are tranq wounds, not necessarily exclusively injection related wounds. And I'd say the big difference between these wounds and typical wounds that we associate with drug use is that they are more necrotic than infectious in nature. And what that means is that instead of a pocket of infection that we can get rid of and treat with antibiotics, the tissue just dies and it leaves these deep ulcers and exposes what's underneath, including tendons and bone. And wounds like to heal from the bottom up. So the most important thing in treatment is to get rid of all that dead tissue, to uncover the wound bed, which then precipitates the healing cascade. And at early stages, we can do that with different ointments and topicals. But at later stages, these more advanced wounds and those that have captured so much media attention, like the ones you've probably seen, this means surgery. So a surgical debridement, going into the operating room to have that tissue removed. But again, that can be really challenging for people who face a lot of barriers just getting to the hospital, let alone staying for these invasive procedures.
So, Matt, I want to turn to you to talk about, we already have a very complex and devastating opioid epidemic situation in this country that has been going on for a long time. Now you have this added contaminant in the supply. How is this further compounding this complex situation?
Yeah, it's a great question. And thanks for having me here with you today to talk about this. When you look at the cost to society from the opioid epidemic, it's estimated to be over $1 trillion a year, right? And that's from a whole bunch of different things. Adding in xylazine makes the medical complications more profound. As Rachel was discussing, like these wounds are slow to heal if they heal at all. Patients can be left with non-functional limbs requiring amputations or just really bad sources of infection. And that's going to add to even giving patients gold standard treatment for their opioid use disorder, doesn't treat the xylazine dependence, and now adds medical complication to this already devastating disease, right? Like we're used to seeing patients who inject drugs who are at risk for lots of different infections, right? Transmissible infections like HIV and Hep C, bloodstream infections, endocarditis, a whole bunch of bad things that sometimes require surgical intervention, sometimes prolonged antibiotic administration. But now we're adding in these devastating wounds that further reduce quality of life, further complicate medical treatment, and makes it even harder to find where to send these patients, because a lot of facilities, be they skilled nursing facilities or drug and alcohol treatment centers, are declining to accept these patients because the wounds are so bad and so hard to manage. They don't feel like they have the infrastructure to provide adequate care for these patients, and keeping them in the hospital for long term just isn't really feasible, right? So it's just added so much more complexity. And then trying to treat the xylazine dependence and the withdrawal syndrome the patients describe as so very unpleasant and looks different than opioid withdrawal, which is actually pretty easy to treat with a lot of different medications, gold standard medication being buprenorphine or methadone. We can usually treat somebody's opioid withdrawal, but the pharmacology, the pharmacotherapy that we have for xylazine withdrawal, one, we don't know what best practices are. And two, we want to be safe with medications, but we want to keep them comfortable and make sure they're able to get the care that they need. And there are no guidelines. So we're kind of working on it and thinking hard about it, but it's really just a layer of complexity that makes it that much more challenging.
Are there ways, Matt, for people to test their supply for xylazine?
So there are now xylazine test strips available. I work in New Jersey. They're actually still considered contraband and are illegal in New Jersey. So we cannot distribute them. And I think this is a state-by-state rule. I don't know what the rules are in Pennsylvania, but you can get xylazine test strips. You can find them online. I think they're fairly reliable. But again, if you're caught with them in New Jersey, you are subject to arrest.
I'm going to come back to that point because I think that some of the solutions for treating the acute xylazine crisis are really solutions that we already know of from treating the opioid epidemic. But first, I do want to talk about those solutions. So, Rachel, let's start with you about what are some of these really obvious barriers to care that we could ameliorate so that people can get the help that they need?
So I think one thing that we're seeing more of in Philadelphia, and I think we will need to see more of as xylazine footprint spreads, is a low barrier harm reduction wound care options like our clinic, where we can and do successfully prevent progression of these wounds, at least when they're caught early. And what I mean by low barrier is removing some of the traditional expectations that we have around accessing healthcare. So, like appointment scheduling and abstaining from substance use. A person with complex polysubstance use disorder should not be expected to be sober when they go to an outpatient appointment. What that actually means is that they're going to be in terrible withdrawal and care, and certainly wound care just won't be possible. But showing up intoxicated is cause for patients to be asked to leave clinics and not come back in some places. And we've seen that. People should be able to come as they are and when they can, meaning flexible drop-in hours as opposed to strict scheduling policies. So folks without consistent access to phones or technology are going to have challenges making appointments and keeping schedules, et cetera. And there's already quite a bit of evidence out there that these models work for people who use drugs, getting HIV care or hepatitis, Hep C care, et cetera. And then what I mean by harm reduction wound care is really about disrupting the typical power dynamics at play between providers and patients, really our whole healthcare system and people, and acknowledging the long history of trauma that our country's drug policy and healthcare system have subjected people who use drugs to, and using that to inform a trauma-informed care approach to any kind of healthcare, but certainly wound care in this population. And recognizing that when it comes to the drug supply and their own bodies, folks really are the experts and have quite a lot of experience, more than most of us do. So leaning on that experience and expertise. But again, there are these advanced wounds out there that require advanced care. And so there's also a great need for hospitals to reevaluate their policies and culture around treating people with a history of drug use to make that care more reachable. And some of the experiences that I often hear about, and I'm sure Matt and I have both seen in our institutions that I think warrant questioning, include systematic searches and confiscation of people's belongings, visitor restrictions that contribute to people feeling very isolated in hospitals, compulsory detoxing because we're not using evidence-based withdrawal management, and even just very low-hanging fruit like not calling people names or blaming them for their wounds. I think the world of academic medicine is really ready to pounce on how to best treat xylazine and learn more about these wounds, but I'd like to see equal effort put towards dismantling stigma and discrimination that contribute to excluding people from these healthcare settings altogether.
Let's go a little bit more upstream. And I want to pick up on a thread that you had in there about when you were talking about regulation and the larger regulatory sphere of these drugs. And is there a regulatory sphere? So Matt, I want to go to you to talk about what are the opportunities here, or what are some things we should be thinking about in terms of actually decriminalizing these things, lifting these constraints, because xylazine is getting into the drug supply. It sounds like people don't necessarily want it in their drug supply. How is it getting in there? What can we do to stop it from being there in the first place?
I think it's a great question. And the truth is, like, adulterants have been in the drug supply for a very long time, and it's always changing. And what that really points to is the fact that the system as it is not a safe one, right? And for a long time, heroin was actually heroin. And then it became fentanyl. And fentanyl was an adulterant initially. And then it just really replaced heroin. So now we're used to not seeing heroin anymore. And we see patients with fentanyl use disorder. And that was not safe because fentanyl is orders of magnitude more potent than heroin, and people were overdosing. And really, the ongoing rise in overdose deaths in the United States is really driven by synthetic opioids like fentanyl and fentanyl analogs, right? And then we've got further dangers with the adulterants and contaminants that are put into the drugs. Why was xylazine added? Well, the leading theory about why xylazine was added is that fentanyl's got a very rapid onset of action, but doesn't last for very long. So xylazine potentiates the high, but also prolongs the effect. But a lot of our patients don't want it, right? One of my patients said that I asked him, can you tell when you get trank with your dope? And he said, yeah, absolutely. He said, I inject it, I can taste it, and I feel like I take my last breath and die. And then I wake up a few hours later and it's horrifying. And then I do it all over again because the withdrawal is so bad. So what's the solution for that? Well, I think you mentioned decriminalization, which is a very important step, but we actually need to have the harder conversation about legalization, because it's only when you legalize and you regulate that you can reasonably assure a safe supply, because it's going to be subject to government scrutiny and testing. And then patients know what they're getting. They're able to get it in a quantity that they know that they're getting it in, right? So it's not like they're buying an undetermined amount of whatever. It has to be packaged and labeled, and they have to know what they're getting. And they need access to all of the harm reduction things that go around that. They need clean needles and syringes and alcohol swabs and sterile water and all of the things that they really need. Because the truth is, on a manufacturing level, the dealers and the high level people who are making these drugs, they're faster and smarter than us. I'll give you the example, a bunch of years ago, it was clenbuterol. I don't know if you remember clenbuterol, but that's like a horse asthma medicine that was in the street supply. And that was super dangerous. And then clenbuterol went away, and then it transitioned to something else. And now we're onto xylazine. So it's like over and over again. It's like lather, rinse, repeat. And I think the lesson that we really need to take away from this is that I think we need to continue to talk about primary prevention, and we need to address social determinants of health and ACEs and all of the things that predispose and increase risk for substance use disorders. And I think that's super important. We need to do that, but we need to also focus on secondary and tertiary prevention and create a safe supply for our patients who may not be ready for treatment yet and are going to continue to use drugs. And we need to embrace those individuals, destigmatize, and say, here's safe stuff for you to use. And let's give you a safe environment in which to use it too. Because we know that when individuals use in isolation, they're at greater risk for overdose and death.
Yeah. And we've talked on this podcast quite a bit about it is such a hard conversation for this country to have around the term legalization. There are a number of reasons for that. There's a lot of historical reasons for that, but we're really starting to get to a point where there really is no other option, but it's not going to happen tomorrow. And in the interim, I'm going to point this to you, Matt. What can these different institutions that are involved in this problem, you've got like law enforcement, you've got the hospitals, you've got the academic world, how can they work together to create a safer space or a safer supply? Or is there a way, you said that the people that are at the top that are actually putting these contaminants into the drugs, they're working faster than you. How is there a way to come together and maybe start to at least be one step ahead of where we are now?
Yeah, I think it's a great question. And I think people tend to be siloed in their approaches to everything, right? We do that a lot in medicine, but there's a lot of work being done to create interdisciplinary, interprofessional teams within healthcare settings, but also reaching out to community partners. And I agree with you, these conversations are really hard to have. And I think the important thing that we do along with having the conversations is really being prepared to listen. We need to hear what our community partners need. We need to hear what our communities need and be prepared to address those things and maximize our resources and create teams that can really affect change. And I think this goes for things outside of substance use disorders, right? We're not here to talk about diabetes today. And then in the setting of, or other chronic health conditions, but we've learned that substance use disorder is a chronic relapsing illness and should be treated as such. We need to come out of our silos. We need to learn what our community partners are doing and what they need. We need to come out of our ivory towers, so to speak, be on the streets with our patients, learn what the community needs are. And we need to be very transparent about not knowing about what best practices are and that we're doing the best we can to help our patients. But it's going to take us some time to learn what those best practices look like. We already know what best practice looks like for opioid use disorder, but we're still really wrapping our head around the xylazine stuff. So we need to be learning from each other and also learning in real life and seeing what are our patients trying? What have they learned? Because they've got the lived experience and could probably teach us a whole lot.
And a lot of what we've talked about, in a sense, xylazine has the potential to truly compound this already terrible situation with the opioid epidemic. But what you all have mentioned is that it also has the potential to double down on what we know works and potentially actually move the needle on getting this epidemic at least a little bit more under control. Like this might actually spur some things that we know can help. We have just another minute, but I want to bring it back to Rachel's point of that this whole crisis started because people who were using drugs sounded the alarm. And they have to be such an important voice in this conversation. And Rachel, how can we involve them more in this process?
I think that's a great question. And I think that's a great question for the folks that we're talking about. How do they want to be involved and what does involvement look like to them? I think harm reduction as a movement is a grassroots movement, but has also integrated research from the jump, because there's always been this knowledge that we need to prove that what we're doing works in the face of a lot of backlash and conflict. So there are some structures already in place at well-established harm reduction organizations where we can work with people who are getting the firsthand experience and have really valuable insight into what's going on. So making alliances with those organizations is very important. And then, as Matt said, just within our own institutions, integrating how can, say, at Penn Medicine, we integrate the voice of people who are using drugs. And I don't know that a lot of big health institutions have forums for that, but there are models for doing that in kind of community advocacy boards or community participatory boards and things like that. So, but it's, as you said, doubling down on some of these things that are already there and really taking them seriously and putting meaningful resources towards them. And I think a sincere dialogue with people who are using drugs is going to allow us to know what makes sense, what is feasible, and ultimately reduce the harms that they experience along the way, but also reduce a lot of the complications and headaches and great expense that we're experiencing across the board.
Rachel and Matt, we are going to be keeping a close eye on this, and we will continue to cover this on the podcast. We'd love to have you back. Thank you so much for your time. We really appreciate it.
Thank you. Thanks for the opportunity.
Thank you, Lindsay.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.